Cass, are you ready? I did some vocal exercises before this to make sure I don't come off too nasally. So we'll see how it goes. All right, it is 1 o'clock, so we are going to go ahead and get started. Good afternoon, everyone. Thank you and welcome to our third long-term home health rule revision work group. It is Wednesday, October 16th at 1 o'clock. Please note that we are recording this meeting, so please avoid any use of PHI, which is protected health information, so that we can post this publicly to everyone who would like to see that, for people who are unable to make the meeting. For those of you who are unable to make the first couple meetings, or if you just like to be reintroduced to me again, my name is Paul Hutchings. I am the long-term home health policy advisor for the department. I also oversee the pediatric personal care benefit and assist with private duty nursing. We have several outstanding HCPF members with us today, folks from CCQI and CDPHE, and some other people helping us out as we go through the meeting today. Unfortunately, our presenter, our wonderful HCBS Division Director, Candace Bailey, will not be with us today. So not only am I going to be facilitating, but I'm going to be leading this meeting as well. So bear with me if there's any slight pauses as I run the queue and kind of watch the chat as well. With me, as always, is my fantastic work partner, Christine Merriman, and we also have Cassandra Keller on the call with us as well to help out with any questions or concerns that might come up. That being said, let's go ahead and next slide, please. We always want to start off with our mission, and that is improving healthcare equity, access, and outcomes for the people we serve while saving Coloradians money on healthcare and driving value for Colorado. Next slide. The purpose of this work group, and we've really mentioned this and really tried to drive this home the past few meetings, is for all stakeholders. That includes members and family members, advocates, really any stakeholder who would like to participate, to come in and help us, the HCPF, our team, advise, and as we review and update our regulations for the long-term home health benefit. It's been a while since they've been updated, so we encourage any and all participation as we go through this process to really make this as easy and as a smooth transition possible. Next slide, please. As we go through the agenda, we've already done some introductions. Please make sure to complete the attendance form. Amanda's helping us out today in the queue, so she's going to drop that attendance form. Perfect. Thanks so much, Amanda. Make sure to fill that out so we know who we're talking to and we know who is available and on this call. We'll go through some brief housekeeping, look at our goals, and then dive into the red line review. Next slide. Quick housekeeping. And this is the same slide we've used for the past 4 or 5 meetings, and I think with all of the PDN meetings as well, so I'm pretty sure I just stole it straight from them. Please mute yourself when not speaking. This includes folks that are on the computer and also on the phone. If you are on the phone, you can unmute yourself by hitting *6. Just remember to mute yourself again by hitting *6 again. Please raise your hand if you have any comments or suggestions. We will try to keep that in order and call on you in order in which it is presented. Please identify yourself and the agency you are representing when speaking, so we know who we're talking to. Again, we have several HCPF members and subject matter experts here on the meeting, so if you drop any questions to the chat box, we will be sure to get to those as well. As we said before, please no PHI. We want to make sure that we can post this publicly. If you have any questions or concerns that you don't feel comfortable bringing up in this work group, you can always email us. The email address is there. It's homehealth@state.co.us. Thank you, Amanda. She's already beating me to it. And then you can always look for the recording and all posted materials that are posted to our home health website as well. On there, you can find our agenda for the day, you can find the slide deck, and you can find the red line draft that we are currently working from. Next slide. Goals. Again, the goal of this work group is to openly collaborate with stakeholders while conducting a thorough review of the long-term home health regulations. Again, I think the thing we really want to emphasize there is collaboration. This is nothing that we are dictating. This is nothing that we're telling you that we are doing. We encourage this to be an open collaboration space, so please feel free to speak up. And if you have any comments or suggestions, we definitely want to hear them. We want to revise any of this language that is outdated or unclear. As I said earlier, it's been a while since these have been updated, so we want to make sure that we are doing our best. And then we will identify any areas that need edits, rephrasing, clarification, removal, or just restructuring. So if we need to move sections up and down, we can do that as well. Next slide. Overview of the long-term home health rules. You can find the actual rules that we are working from. Amanda, if you wouldn't mind posting that so people can go directly to the CCRs. And then the draft rules that we are working on, including any of the updates that we made last time, are on the home health website. So you can link that directly there as you want to as well. And again, as we said before, feedback and collaboration is highly, highly encouraged. This meeting doesn't run without you. So otherwise you have to sit here and listen to me, which nobody wants to do for an hour and a half. Next slide, please. General considerations as we are going through this process. Again, we are recording this. We want to make sure we are documenting everything that's being said, either in a chat or live or through the phone. We do have a listening log ready to go from our last meeting. It just needs to be posted. So we're working with our team to get that posted ASAP, but that is ready to go. As you'll note, certain words haven't changed throughout the entire document. Example, client will go to member, and we went through that in our last meeting. Some cases we'll kind of reorganize sections. We want to make sure they're easy to read and make sure they flow smoothly. And then we added some definitions, and that's something we went through last time as well, and definitely spelled out any acronyms in their first use. Next slide, please. Quick slide here, and this is just some general, I'm going to say general feedback from it's not everything that we went through, but for those of you who were not at our last meeting back in September, just a few key points that were brought up. We wanted to add the word school to place of service, and you guys can find those in the sections mentioned there. We were asked clarity to reimbursement and services allowed in an IRSS setting. Also clarifying language to the section regarding brief nursing visits, specifically around insulin. We want to make sure to keep in the CNA tasks. That's something we had taken out, but overwhelming majority wanted to keep it in, so we are definitely keeping it in. And then clarification regarding parent CNA expectations. Next slide. Okay, now here's where we're going to dive into things. Danny's just going to take a moment to go and pull it up. What we're going to do and try to get through today is we're looking at therapy. We are going to look at supplies, documentation, and then prioritization. If we get through that, we're going to keep pushing on. If we don't, that's fine as well. We do have another meeting on the blocks in November, but we're just going to try to get through as much as we can. So Danny, if you want to scroll down, we are way down to therapy services, and I'll give you a second to go ahead and get there. Yeah, Chris, go ahead.
Hey, Paul, thank you. Is there any way this can be made slightly larger, the print?
Yes, we are going to do that. As soon as Danny gets down there, she'll
Okay, perfect. Thank you so much.
You bet. Thank you for pointing that out.
Do you have a oh, here we go. Okay, now I see.
Got it. Perfect. Right. Perfect. Okay. All right. So we're going to go ahead and start this. And again, with this work group, please note that we have not gone and changed a whole lot in here. Just change things based on our meeting from last time. Again, client to member. Ordering practitioner to physician or a lab practitioner. Most of the meat of this has not been changed, but if something is unclear or if there's something that you would like to see changed to make it easier for you, please drop a note in the chat or raise your hand and we will go through this little by little. All right, so we're going to start with therapy services here. And Danny, what we did last time is kind of did a slow scroll, and then if someone had a question, we'll stop on that point. So we're going to go ahead and go through here. And as you can see, again, client to member, ordering practitioner to allowed practitioner. Keep on going down. We're going to get into the actual therapies. Just took out this giant section here, mainly changing our address. Yeah, you can go keep going. We're getting into limitations, and you'll notice a lot of this for PT, OT, and speech. It's kind of repetitive. But again, if there's anything that you guys want to see, and we'll take just a brief pause here at occupational therapy, Danny. Everyone okay with the PT portion so far? And again, you'll notice occupational therapy and speech therapy also have very similar rules and regs. So, okay, let's go and keep scrolling. Again, we're looking at client to member, going through any limitations. You can see nothing major has been changed. Speech therapy as well. Okay, keep going. Looks good, and we'll pause here just to take a quick break. That went a little quicker than I thought. Anyone have any comments or suggestions, any stakeholders at all regarding the therapy sections, specifically regarding PT, OT, or speech? Okay. As you can see here, and this was, we redefined this last meeting. So we're changing telehealth services, just to name it, to remote patient monitoring. So again, you'll see just the changing in nomenclature there. So we can go ahead and go down. Okay. We went ahead and wrote out UL, which I actually had no idea what UL meant, but that means Underwriters Laboratory. So we just went and spelled that out for everyone, so we knew what that was. Again, we're looking at client to member. Okay. Going down there. Moving on to limitations. Again, hopefully everyone had a chance to kind of review this stuff. And again, we'll pause at supplies, Danny, to review some of these things regarding therapy service and remote patient monitoring. Again, we'll pause here before supplies. Any questions, concerns, suggestions? No? Okay. We'll go ahead and scroll down just a little bit there to supplies. And as you can see, this is quite a massive section, so this might take us a bit here. Again, nothing's changed, just looking at client to member. Okay. We'll move on to documentation. Again, client to member, again, scrolling down. Looking at the 45 or the plan of care requirements. Again, we are not changing anything. We're not moving anything around in regards to what is required in the rules and regulations regarding the plan of care. Just looking at renaming things as we did last time. Yeah. We'll keep scrolling down to the next page. Great. Okay, we'll stop here at E. Quick pause. Anyone from the departments, any other stakeholders have anything that they'd like to add? Okay. We're going to look at any additional required chart documentation. Okay, we can scroll down through here. Again, removing this area here, especially with our old address. But again, this kind of cleaning up the language. Okay. Yes, Kelly, go ahead.
Hi, my name is Kelly Panetta. I'm a consultant for Home Health Agency with Amity Healthcare Group. Back on the documentation, on the plan of care, you know, it says, K, little letter K, should include the specific duties, treatments, and tasks to be performed during each visit. Something that we commonly find, specifically as it relates to CNAs, is, you know, not specifying the duties that they're going to provide at each visit. So I just want to confirm that I mean, includes, you know, all disciplines, including CNA. So for example, you know, shower, AM visit, etc. That's how I understand it. I just want to make sure that's correct.
Sure. And Danny, would
So-
you mind scrolling up to that section real quick? It's small. Small.
Sorry, what section is that?
It's under
documentation.
plan of care, little lowercase k. Oh, there.
This one?
Yes.
Okay.
Frequency, expected duration. Now I'll keep going down. It's little Roman numeral 1 under K. Yes, the top one. The specific duties, treatments, and tasks to be performed during each visit. We commonly see, where the documentation on the plan of care, they will just say CNA to assist with ADLs or, something like that. But I understand this to mean that each task to be performed during each visit should be specified on the plan of care. So my example was, CNA to assist with shower every AM visit, if there's multiple visits a day. I just want to make sure I understand the language and the regulation correctly.
Right. So what I can tell you from personal experience, with the 45 and with every single visit going through, in CCQI team, feel free to jump in here at any point in time. There's a CNA task that has to be done. It's very, very specific. Yes, no, refused. So that should be included with the 45 and should be documented every single visit. Now, if a physical therapist or a nurse is going out there, they don't have to list everything in their notes every single time, but that CNA task sheet should be filled out specifically and gone over with the member at their very first visit during the initiation of care.
Right. It's just that the plan of care is the actual order, whereas the task list isn't, signed by the physician or provider. So we often educate our agencies that they have to incorporate, the specific tasks to be performed during each visit on that 485 plan of care, because it is the order signed by the provider. So that's how I've always understood this part of the regulation.
Okay, let's go ahead and do this. We will mark that down and put that on our visit and see if we can put some clarifying language in there for that. Unless the CCQI time has anything else they'd like to add? Nope. Okay.
I appreciate it.
All right. Yeah, Erica, we talked about this last visit, and we took this from the private duty nursing rules and regs, so we changed that in there as well. We can get back to that as well once we get through this. Okay, let's go ahead and keep going. Okay, and we'll go ahead and pause here at prior authorization. Christine, since you were looking at the private duty nursing things and did a lot there, do you want to go ahead and speak to the remote patient monitoring and kind of the language behind that and the thought process behind changing that?
Sure. Remote patient monitoring. So this is for the devices in the home that gather data on a daily basis, such as blood pressure, weights, O2 readings, those type of things. And then it translates that data to the home health agency, who then has a nurse or clinician who is able to read that data and monitor the well-being of the member. This does not speak to like telemedicine or doing visits remotely, which, as we've had many discussions, there are certain situations where remote visits do work, and then there are certain situations where those remote visits do not. So this section in the long-term home health rule is about the remote patient monitoring. And when you read through it, it's about that type of equipment in the home and who's eligible and how to notify the state who is receiving that information or receiving that care and services, and how long that is anticipated. And then there's some different revenue codes as well that go along with that. So there's a cross in the billing manual, cross-reference of how to do all of that. So remote patient monitoring and telehealth are, telehealth is used for a lot of things that are kind of bunched into that. And so we're trying to make it a little more clear. So hopefully by redefining that, we will be able to clarify that. And we may need to, Erica, put in somewhere about remote visits and when those are allowed and when they are not. I know that Chapter 26 for licensure rules has some information. So we can discuss that now, Paul, or see what stakeholders.
Yeah, no, I'm fine opening up for discussion before we get into prior authorization. If anyone has any thoughts or feelings about that. Okay. So we can always put in some clarifying language regarding remote visits. I don't hate that idea as well.
Yeah, I think that we should, just because I know that there are thoughts and feelings, and I'm assuming that some of those people who email us about that are in this meeting. So I'm surprised they're not sharing their thoughts and feelings. But we do need to address that, I think, due to the, during public health emergency, there were an increase in use. And now with that unwind, that we might need to specify the instances where that is proper.
Yeah. One other, go ahead, Kelly. Yep, you might be on mute there, Kelly.
I sure was. I just wanted clarification on back on the additional required chart documentation, 8.5207E8. Yeah. This is clear documentation of skilled and non-skilled services to be provided. Does that mean also, like, if they were getting the non-skilled being personal care, or I just wanted to clarify what non-skilled is in that particular item.
Yes, I personally think that would go to like pediatric personal care, which needs to be provided all that information in the 485.
Right. So if, let's say the patient was receiving skilled care, but also was receiving personal care from, under like a waiver program or something that's specified. Okay. I just wanted to clarify.
Yep. And we can even say, like, for example, X, Y, and Z. We can take that back there as well to provide a little more clarification.
Thanks, Paul. Appreciate it.
One other note that was just brought up, there is just a very, very brief mention regarding physical therapy assistants and occupational therapy assistants and their role. I didn't know if anyone wanted to discuss that, because right now, under both the PT and OT sections, it just says the assistants can render home health therapy, but shall practice under the supervision of a registered occupational therapist and or physical therapist. Do we feel like we need to flesh that out a little bit more? Do people want to bring that out? Maybe even point out the fact that that's not mentioned in the speech therapy section, and providing a little more clarification to that. What are people's thoughts, feelings regarding PT, OT, and speech assistants, and what their rules and what their roles are? Yeah. I know.
Sorry, from what I understand, there's no such thing as a speech aid.
Not a speech aid, a speech assistant.
Okay. So like our speeches in the state of Colorado aren't technically licensed.
And
So
that's why I was wondering if people want to put language. So with the speech therapy assistants, they can practice, but it has to be under the direct supervision of a speech therapist, like eyes on contact. And there's another, it was a speech therapist. I need to look it up. There's another classification they can get that would allow them to practice independently. But yeah, but speech therapy assistants are not allowed to practice independently.
okay.
All right, we have a question in the chat here, and I'm going to open this up to the HCPF staff as well. The 45 needs to include info to justify what makes the service skilled. Why is a CNA needed for bathing assistance? Because a PCP, which is non-skilled, can also assist with bathing. If the client is also an HCPF, the CNA will need to have justification as to why it needs to be a CNA for bathing assistance, so we can ensure no duplication. So yeah, that is a very good point. Does anyone from the HCPF side would like to comment on that?
Yeah, great shout out there, Sandra. It does, the 45 needs to be completed to include all diagnosis, medications, equipment, and then the narrative from the nursing assessments, stating why things are at a skilled level, why they need the assistance at home of the skilled level. So that 45 is a very important document, not only for like the PAR process, but also for capturing the orders and the picture of what is happening. Now, there can be, you know, 45s I've seen that are quite lengthy, but there are also addendums that you can add in there if needed to support that. But a great point there is that we always are asking, you know, why is, because we have so many different levels of care, why is it at this level then, and why is this the appropriate level? So the clearer the picture on the 485 or the documentation, then the better. I always suggest making sure that 485 is really solid.
Right. Thanks, Christine. All right. Before we move on to prior auth, any further questions on therapy, remote patient monitoring, supplies, or documentation? Okay. Annie, we just want to go ahead and scroll down to prior auth. Okay, going through here. Again, we're not looking at changing a whole lot of things other than just some basic wording from client to member. Scrolling down, we're going to go through acute home health first, and then looking at long-term home health. Again, we are looking at specifically here what a PAR should include and any other documentation. Okay. All right, Dane, let's go ahead and pause there while we take Shauna's question. Go ahead.
Hi, this is Shauna from Flint Hills Gateway. Can you hear me?
Yes, we sure can. Go ahead.
Great. I'm looking at number 1 under 8C, and it says long-term home health services do not require prior authorization. And that's always confused me. I'm wondering if you could provide some clarification on that, because we do prior authorization for long-term home health services.
Yeah, you are right. Let me see. Section, would need to look up what section 8.017.e is. So we can go and tag that for a little more clarification while we're looking at that. Katie, why don't you go ahead? Katie, you might be on mute.
Can you hear me now?
Now I can.
You can. Wonderful.
Yeah.
Okay, sorry, I was on the wrong setting there. I wanted to sort of lift up Erica McClurg's question in the chat, and I admit to some confusion. I know that there's this push for this new nurse assessor that's going to be like an additional step in the UM process, and I assume that there's going to have to be a whole bunch of rules rewritten regarding that, and so I'm curious how that would affect the PARs here and this rule rewrite, since that's sort of to be TBD, like in the future happening. So I would love more clarification on that.
Sure. And I'm going to have Cassie go ahead and speak to that.
Sure. Before Paul, were we still trying to answer the question about the 8.07?
Yeah, we looked it up. It's actually that's under habilitative services. So we can actually clarify that and specify exactly what that's for.
It says actually it's a medical prescription is required for covered services. The provider shall be responsible for submitting a prior authorization request that includes a medical prescription to the department's designee for all covered services under 8.17B. Following the receipt of a complete request, the department's designee shall approve or deny all requests for prior authorization and shall determine the length of time that the service is medically necessary. A prior authorization request shall be effective for a length of time not to exceed 12 months. So I don't know exactly what this is. And then it's referring back to B about habilitative therapy. So I don't know exactly what this is speaking to, but I think we can certainly make a little more clarification here, just because it's weird to say long-term home health does not require prior authorization and then just refer it to a section.
Great. Yeah, let's definitely take that back and we'll mark that on our list. So thank you for bringing that up.
And then to the questions about the PAR process and the nurse reviewer, the PAR itself will not look any different than it does today once the nurse review process is implemented. In terms of the process, we're hoping that it is very minimally different from a member perspective in terms of the length of time, what all has to happen. Obviously, a member is going to interact with this nurse reviewer in terms of having this new assessment completed to go through the skilled care. But we're hoping that that process will lead to a recommendation for hours or a level of need for services that then all gets transmitted over to the URUM vendor where a final medical necessity determination is made. So yes, the assessment will need to be included in here as well as the assessment process. That's all going to be outlined in regulation, but just not quite at this point. So hopefully that helps to give a little bit more information about what that process looks like and how it interacts with the PAR process.
Great. Thank you, Cassie. Irina, you're next. Go ahead.
Hi, good afternoon, everybody. Irina with Amity Healthcare Group. So two-part comment here. So number one, I think it's very important now that we've had a change in the long-term home health processing, especially for adult long-term home health, that whatever we have in our rules in Section 8, 520, right, matches the verbiage and the wording we're using for utilization review. So when we say there's no prescription in the utilization review or any memo that we've, received, right? We're talking about plan of care, master company, the PAR, any other supporting documentation for medical necessity and stuff like that. So I think it's very important that it matches and it's consistent, so it's clear and doesn't leave any questions or uncertainty between, for the providers, no matter which resource we are reaching out to. So that's comment number one. Comment number two, what do you guys think about? So some time ago, we used to have sort of, timeframes that was holding case managers accountable for keeping up with certain timeframes and return the approved PARs. And obviously we had lots of issue with this in the past year, but it used to say that the provider had 10 days to submit the PAR, and then the case management agency would respond within 10 business days from the date of submission. Just to hold the utilization management company accountable as well, and we have some timelines and processes that we, kind of follow. My thought or suggestion, maybe considering including that in the rules. Like, yes, we have certain rules as providers, but the reviewers, the PAR reviewers, have to have certain timeframes as well, and then maybe that should be included in here as well.
Yeah, thank you for that, Irina. Definitely going to made a note to make sure that the operational memo that was just recently sent out on the change for adults, that language matches with that update. And then also the timeframes are going to remain the same for the vendor as they always have. We're not planning on changing that. So those timelines will stay. And we can flush out maybe adding that into some of that language like we did with the PDN rule.
Right. And there's still timelines for the provider, but there's still no timelines. Whenever the revisions were done in between the timelines that used to be there for the case management agencies at that point, right? The timelines are no longer in the rules. So.
Okay.
Christine, does the I haven't looked at this in a minute, but does the long-term health rule have timelines for the utilization management contractor in here, like we do for PDN? I think if so, we can make sure, we're looking at timelines there. But in terms of case management timeline, as Christine mentioned, it's no longer with the case management to submit those PARs. So we certainly wouldn't want to add those in here, but we can see if there's a need to add them for the utilization review process, similar to what's in PDN.
I don't think there are. There's, information around the requesting appeals, I believe, or submitting it for reimbursement. But yeah, I think we need to.
Let's talk about that.
Yeah.
And while I'm here, just going to speak to the couple of questions, comments, Katie, you've got in there about, will there be rule meetings like this to determine what the nurse assessor process looks like? Yes, we are in the process of getting our request for proposal posted. We hope to have that here in the next month. One caveat, or not caveat, as warning, is that during the RFP process, we're very limited in our ability to engage with stakeholders, talk about this. And so we will be kind of pushing that off a little bit, probably until the, I'll give a season like later winter, early spring, just so we can get that RFP executed and moving forward with executing a contract. But we absolutely want to talk to stakeholders about what that process looks like, what training looks like, and what the authority those recommendations have. Because the nurse assessor is not making a determination on that medical necessity, the appeal process and any reconsiderations and all of that work would still continue with the URUM vendor. It would not be with the nurse assessor. So if you have questions or concerns about that, the nurse assessor is one component of that medical necessity review. It is not the totality of that. So if there is a concern about the outcome of a medical necessity review, it would continue to be with the URUM vendor. Katie, go ahead.
Hi, thank you. I appreciate this is not like totally on point to hear, but the question I have is, I heard what you said earlier that the PAR process won't change. The part that I'm not quite getting is, my understanding is right now it's the home health agency's responsibility to conduct let's say the acuity for PDN or to conduct the assessments. And so now we're going to have an additional vendor. And I'm just curious, like, what responsibilities the home health agency has, what responsibilities that new vendor is going to have.
Yeah.
And then the last piece is just for that nurse assessor, are they making a determination of skilled versus unskilled? Because that seems to be really like not determinative, but a huge part of what the UM is doing. And so that's the part that I'm sort of not getting.
Yeah.
Thanks.
Yeah. And I'll get to that. You're right. We're a little off topic here. Definitely want to kind of stick to getting through these regulations today. So I think the question was, will the PAR look different? And that was what I was trying to answer for Erica. The PAR won't look different, but the entire process for a member to go from a referral to an executed and approved PAR is going to change, and it will look different. Right now, the home health agency conducts an assessment and says, here's the services that we believe you need. That 485 and care plan gets submitted, not for home health necessarily, but for PDN gets submitted, and a medical necessity review takes place. What instead is going to happen is that, a referral is going to happen. That nurse assessor is going to complete an assessment, have a conversation with the member about what their needs are, skilled and unskilled, and then they're going to make a recommendation of what those services are, and do a little bit of benefits counseling to say, hey, here's what your options are. Consumer directed, if you want to go under an HCPF waiver service, if you want to go with private duty nursing and long-term home health, here's kind of what your options are. There's going to be a care plan that has to still be created by an agency based on how many hours that person is recommended to have. All of that information is going to be transmitted and provided to the URUM vendor, where a final medical necessity determination is made. And so the home health agency still plays a role in that care planning process, but they're not completing the assessment and saying, we believe you need X amount of hours based on either an actual assessment they're conducting of the member or just based on observation. So they're not going to be doing that part, but they're still an integral part of that care planning process. I will hand it back over to you, Paul, to keep us moving on our agenda.
Thanks, Cassie. All right, Danny, if you want to go ahead and scroll down, and Shauna, again, thank you for catching that on C1. We were able to pinpoint where that actually is in the rules and why that's there. So we will definitely get that clarified. Yeah, Ellen, go ahead. Ellen, you might be on mute. Okay. Danny, we keep going. Ellen, if you can get yourself, there we go. Looks like you're off mute now.
Hello?
Yep, there you go. Yeah, Ellen, go ahead if you'd like to go and speak.
Hello? Can you hear me?
Yes, we can hear you. Go ahead. Ellen, if you'd like to go ahead and put your question or comment in the chat, we can get to it. Or if you were able to maybe raise your hand here in a little bit if you figure out your speaker is working. Okay. Danny, let's go ahead and pick up where we went off. That sounds great. Continue scrolling down. Again, we're just looking at client to member. Getting up now to EPSD services. Looking at that. Follow that up with remote patient monitoring. Again, just a little bit of a title change there. And that brings us up to reimbursements. So it is now 1:45. We've gone through the 4 major sections we'd like to. If it's okay with everyone, I think we can go ahead and push through and get through this last reimbursement section. And does anyone have any other questions or comments regarding prior authorization before we go ahead and push forward? Okay, let's go ahead and keep moving. Danny, thank you for doing that. Again, we are not looking at making any major changes in this section here. we're looking at just moving, again, client to member. Scrolling down a little bit further, this is great. We're talking about documentation, different services, reimbursement for supplies. One thing we will do here, and what we definitely did up above, is taking out some of this all caps language and make sure that's just in normal written links. So go ahead and scroll down a little bit further. Any restrictions? We took out number 4 here, and we can pause there to see if anyone has any questions about reimbursement as we go through. Okay. Look at improper billing practices. Again, nothing major is being changed. And then we're just going to pause here at compliance monitoring. Again, take a little break. Does anyone have any? Okay, Ellen, here we go. Okay, I'm looking at B.4 under authorization times. I'm not sure what is meant by the department or designee may initiate PAR revisions. The department or designee used to be the CMA, now will be with the Centra. They wouldn't have the information they would need to initiate a revision. Dan, if you wouldn't mind scrolling back up so we can all be on the same page there under 4B.
Sorry, there's a lot of 4Bs.
Sorry,
We're talking prior authorization, so it's a little higher.
Perhaps.
Right here.
Okay, with initiating PAR revisions, that's will also be taken care of by the home care agency as well. There'll be ones that also will be initiating PAR revisions. So I'm not quite. We can add some clarifying language there if you'd like. Anyone, if you see there under 4B, it says the department or as designee may initiate PAR revisions if the plans of care indicate a significant decrease in services. Again, any stakeholders, anyone from the department have any clarifying language they'd like to throw out there to help make this a little more clear? No? Okay, let's go ahead and just flag that. Amanda, go ahead.
Hello. I was just wondering if maybe it would be a little bit clearer for them to say can recommend PAR revisions or something similar, because they, the PAR would obviously be already submitted. They would just be coming back and saying that our documentation doesn't indicate that they qualify for the higher level of services. So maybe just wording it to say that they're making a recommendation for different services or something similar to that, I guess, if that's what they mean by that.
Sure. Yeah, like that.
That's a good suggestion, Amanda. I think that's exactly because I mean, the department doesn't make revisions, but you're right. If there is, if the plan of care does not match up to the services being requested, we would, or the URUM vendor would ask for a revision to be made to that. So I think that's a really helpful suggestion. Thank you.
Okay. We only have 2 more sections to go, and it takes up maybe about a page and a half. It's general, it's compliance monitoring reviews, and then denial, termination, or reduction in services. So let's go ahead and jump to those. All right, there you go, just passed it. Okay, let's look at 10 here, which is compliance monitoring. So we can go ahead and scroll down there. Again, nothing major has been changed. And then 11 is denial, termination, or reduction in services. And that's the end. I know those last 2 went quick. If you need us to scroll back up to take a look at either one of those 2 sections, please let us know. Otherwise, yeah. We're at 150. The only thing, Cassie, let me know your thoughts. We can go back up to that CNA task list and kind of show them. Obviously, we're leaving that in, but we did make a small little minor change. Maybe we get ideas and thoughts on that for the last 10 minutes.
Yeah, I think that would be a good use of time. Thank you, Paul.
Yeah. Hey, Danny, if you wouldn't mind, just go ahead and maybe you can we can unshare your screen for a second so you scroll back up to the CNA task list, that we don't make sure everyone's getting motion sickness from lots of the scrolling. And we're going to go up to a section that we had actually previously taken out because it did take up quite a bit of room in the rule. But after listening to everyone at the work last time, it sounded like, I mean, the majority, if not everyone, really wanted to keep this section in there. So we're going to go up to, that way everyone following along at home. Okay, definitions. Service types.
So it's going to be under 8.520.5.b. So it goes under what is under the certified nurse aid services section. That's where it breaks out what are skilled certified nurse aid tasks.
Perfect. And Danny, if you wouldn't mind just scrolling down just a bit, there's a section called certified nurse aid tasks. Perfect, right there. So we went ahead and let this in, and we were discussing this during our meeting the other day. And one of the suggestions from our last work group was, you'll see under here under ambulation, number 1, previous client is unable to assist or direct care. And the thought and feeling from the work group was this is quite ambiguous and really just taken as a very subjective way to interpret this. So we changed this to, and again, let's definitely open this up and hear your guys' thoughts. Client is unable to assist and direct care. So that way it's not quite so open to interpretation, and just replacing that or with and. And we'll go ahead and start with Chris. Go ahead.
Well, I think the intent is good that you have to do this, but what this does is make, what the way that this written means that you have to meet both criteria as opposed to one of them, which is what or was. So you've made it, are there situations where you would be unable to assist, but could direct your own care? Could you direct your own, is it, you've made it now so that you have to be able to do both. It seems to me. Was that the intent?
Well, I think the intent really was to make us very, very specific that yes, to do both, because what if someone was able to assist and not, it's just open is very, very ambiguous before. If you have any suggestions on how to better rewrite this or how to interpret it, we are definitely
tell me what is your goal, Paul, because right now the way that you changed it, I mean, I don't think that and is any less ambiguous than or. One just includes both items and one only includes one of them.
Sure, and please note this is not just me. I mean,
no, I'm not.
The department's thing.
I am not saying that.
Maybe we can make it someone from CCQI that was in the meeting with us and would like to kind of explain why we thought this would be a better interpretation, adding and instead of or.
Because Paul, when you say that when this is an ambulation task, if you're unable to ambulate, that has really nothing to do with being able to direct care. So you would probably meet this simply by not being able to ambulate. But the way this is written, you would have to also not be able to direct care. I don't think that's what you meant, but there you go.
I 100% agree with you, and you were definitely pointing out some very good points.
Okay, thank you.
Let's go and we'll take us back to the table. Unfortunately, I don't think we have anyone. Craig, just to know if you want to jump in or if someone else is here.
Yeah. Go ahead, Craig.
Well, Paul's going to make the same comment. I think the point was to bring this, I think, to the larger group here and hear what these questions are. So I think this is feedback. It's helpful. If there's still more clarification that's needed, we're happy to dive into this a little bit more.
Yeah, I think that's very helpful, Craig. Dulce Warren here, and we really love your feedback and want to hear more of it. Together, I mean, they have different meanings together and separate. So I certainly hear your feedback, and also we're looking at it separately also, as well as related. So yeah, back to the drawing board on that. But some of the rationale was if the client is unable to assist, but they can follow directions, same as if they can't direct their care, but they can follow instructions, that's something different than unable to assist. So combining them, is something we need to look at, and separating them is something we need to look at. I'm talking in circles, but we really do love your feedback. That was kind of our thought process there.
Great. Thank you guys both. Irina, go ahead.
Just a quick comment. I know there should be a certain formality to the language that we're using in rules and regulations, but we're also trying to make those easily understandable by the providers who actually perform care. What about including some examples under each section? For example, patient needs help with movement, even if maybe they're using the assistive device, or requires a certain, I don't know, just little, like more specific examples that could help the providers understand. Again, I know it's the language issue too sometimes, but just a thought.
Yeah, and I agree with that. And I think when we develop that task work list, we were talking about before, that would probably be a better place to put those examples in as opposed to into rules. But again, I think the feeling was last time they wanted to leave this into rules, but also develop a task list as well, which we are going to be developing. So I think the examples would probably be better suited for that.
And I think we can also, maybe as a point of reference, look at some documents that are available for IHSS HMA task, because some of them kind of similar. But I think that tool that's available on IHSS resource side is a little bit more detailed of what cannot be done. Just another thought.
Perfect. Thank you. I agree. Let's go ahead and take a quick look at some of these comments in chat with our last few minutes here. Sean says, could we use and or? Yep, that's definitely a possibility. But again, we wanted to take out the ambiguity. But I think what we need to do is take this back to the drawing board, and during our next meeting, present that and come back with a definite, better idea and a better way of saying that. Irene, I'll get to you here in just a second. I'm just going to run through some of these comments. Kelly, I think to clarify, if all must be present of these conditions, make present, make it a skilled task. Yes, we're looking at skilled versus unskilled. Erica says, hi, Craig. We missed you. I just saw you at the meeting earlier, so I don't miss you that much. So sorry.
That's your feedback, Paul.
And I think I'll see you here in a little bit as well. Could we further define these language if it's not already? Again, yes, Jen, I think it's definitely the feedback that we are getting is that clarification is needed to take out the ambiguity in this. Katie, if we can get a better understanding of what was found to be unclear here, that would help to assist, or what direct actually means without understanding the concern. It's hard to know if going from to or impacts them.
Craig, Paul, if I may, I think what we were trying to make it clear here is we're looking at what are skilled care tasks that can be done by a CNA, and just the nature of having assistance with directing care does not make that task skilled. So what we were trying to provide clarification here is that if you cannot assist and direct your care, then that could make your skills, your needs skilled. But just because you cannot direct your care does not mean you have a need for skilled care. So that's the reason why I'm making that change here, because before I'm saying or, it would mean that just by nature of not being able to direct your care, it means it's skilled. So that was the purpose of this change here. But if we need to go back to the drawing board a little bit further and clarify, we absolutely can. But that was the intention behind this change.
Great.
Thank you, Cassandra. That was very clear.
Yeah, you got it, Jose.
I know we talked about it a lot, so great questions.
Irina, for the final word here. Do you have a final comment before we close out, Irina?
Oh, shoot.
Okay, I guess not. Paul, you want to take it from here?
Yep. We're going to pop up over to the, oh, you there? Nope. Pop over to this slide deck real quick and we'll go ahead and close things out. All right, so what's next? So we made it through all the sections. What I would really like to do is next month, it'd be November 20th, is to go ahead and have one more meeting where we kind of just go through everything one more time and really highlight the clarifying language we used and make sure to hit any of the high points and the things that caused discussion today and last workgroup as well, so that we can put a ribbon and a bow on this thing and get it nice and tidy. If you have any other feedback, comments, suggestion, we're going to drop the link for the feedback form here in the chat, so you guys can put in any type of comments you have, and we'll make sure that also ends up on our listening log. You can also email us at the homehealth@state.co.us. Just make sure to put LTHH rule comments in that, and we'll make sure to get those over onto the listening log as well. And then going forward, you can definitely look at our websites and make sure you can take out any agendas coming up forward. And the slide deck is already posted, and we will get this meeting posted as soon as we can. And real quick, let me go ahead and drop those those links in there real quick for you. Feedback form is coming in. And then our website is on there as well. All right, I'm going to pop over to the next slide. Again, thank you so much for being here today with everyone. It's been way more done than we thought possible. We could not do this without your help and support and collaboration. Again, if you have any other questions, comments, or feedback, please feel free to direct them to us, and we'll get them posted as soon as we can. All right, and I think there's just one more slide. No, two more slides. I missed it. Perfect. Okay, with that, we're going to wrap things up. Please look for our next agenda coming out. Our next meeting will be November 20th. Same time. It will be on a Wednesday. And again, we'll just go through the meeting. I don't think it'll take that long to make sure we're hitting any the clarifying points. So again, thank you all for being here. We appreciate your time. Thank you to the HCPF staff for jumping in and helping out and providing some assistance as we go through this process. All right. Thank you, everyone.